I just want to start off. Thank you so much, everyone, for joining our webinar today, Preparing for FHO Plus, What Ontario Family Physicians Should Expect. Let me start by introducing myself. My name is Daniel Brenner, and I'm the Senior Director of Operations at Doctor Care. It's great to see so many people logging in. Thank you so much for taking the time out of your day to join us. Let's jump right in. With the Ontario Physician Service Agreement having expired in 2024, we've been closely watching ongoing negotiations between the OMA and the Ministry of Health. The latest outcome of the new PSA introduces an exciting new concept, the FHO Plus model. If you're currently in a FHO or considering transitioning to one, we're going to help you understand what changes you can expect as a physician and how to best prepare for them. We're going to walk you through the breakdown of the upcoming FHO Plus model, including the streams in which you'll be compensated, new and enhanced components to the model, as well as things you can expect. We'll also go through the change in compensation under the new FHO Plus model. We'll be ending off with our Q&A session and discussing how Doctor Care can help you navigate these major changes in your practice. It is important to note that the information we are sharing today is based on what is currently known and the most up-to-date information available from the OMA. We expect more information to be released in the coming months, and we will be sure to keep everyone updated. Before we begin, a quick note, the session will be kept to 45 minutes. You are more than welcome to submit your questions at any time through the Q&A function, and our team will do our best to address your questions throughout the webinar. Many of you are already familiar with Doctor Care, but for those who aren't, we are the largest provider of billing and practice support to over 4,000 physicians across Canada. On average, we have helped doctors recover $25,000 to $30,000 in revenue per year. We also support approximately 25% of all FHOs in Ontario. Our solutions and services are designed to help doctors optimize their practice, maximize their revenue, and improve patient care. Let's go through some webinar logistics before we jump in. All attendees are in listen-only mode. We are recording this webinar, so it will be available to you after the event. As mentioned before, if you have any questions during the webinar, please submit them in the Q&A feature, and our team will do their best to answer them during the session. We'll also leave some time at the end for any questions we may have missed. If we are unable to answer your question, one of our team members will follow up with you after the webinar. Over the years, Ontario has developed a variety of physician payment models to suit different practice styles. Among these models was the Family Health Organization, or FHO, established by a group of family physicians in 2004 to support team-based comprehensive primary care. Post the COVID-19 pandemic, changes were necessary to address the significant gaps in physician compensation and the ever-changing healthcare landscape. The new FHO Plus model is an update to the existing FHO payment structure. It's not a full redesign, but rather an effort to address some of the long-standing concerns and inefficiencies. It also aims to recognize the full scope of physicians' day-to-day work, including indirect care and administrative tasks. This model upgrade is great news for achieving fairer compensation for physicians and improving the patient experience. So, you might be most curious about how you'll be paid under the FHO Plus model. Not everything about your compensation is changing, and some of the categories may be already familiar for you. Your earnings will come from 4 updated sources. Capitation. Under the current model, there are 2 types of capitation payment, the base rate payment and the comprehensive care payment. In the FHO Plus model, capitation will consist solely of the base rate payment, as the comprehensive care payment is being repurposed into other categories, which we'll explore further in the slides. Hourly time-based payment. This is a new addition that compensates physicians at a fixed hourly rate for both direct and indirect services, as well as clinic management. Shadow billing. This is the rate at which you're paid for in-basket services for rostered patients and currently sits at 19.4% of the fee value for in-basket services. And patient attachment bonuses. Also new, these bonuses reward physicians between $100 and $270 per new rostered patient, depending on whether they are new to a FHO or have been part of one for some time, as well as the patient's age and rural index for Ontario, or RIO, will be factored in. You will also continue to be compensated through out-of-basket codes, premiums, and fee-for-service billings as you previously were. Together, these categories represent a shift in how compensation is structured, with the goal of creating a more balanced, transparent, and sustainable payment model for physicians under the FHO Plus. Before we discuss the changes from FHO to FHO Plus in detail, here's a quick overview of the differences among the fee-for-service, CCM, FIG, FHO, and FHO Plus models. As you can see, the introduction of the FHO Plus has added some extra revenue streams and increases compared to other payment models. In particular, the time-based payments, as well as compensation for administrative time and indirect care, offering more opportunities to maximize your income. Now, let's dive into details of what you can expect to see moving into the FHO Plus model. Let's start off by discussing what is new to the model. One of the most notable changes introduced in the FHO Plus model is the addition of hourly payments. Another important addition is the patient attachment bonus. In terms of what will be enhanced, we'll be talking about the increases to shadow billing rates, hospital billing, after hours fees, select procedure fees, and increases to the Group Management Leadership Program, or GMLP. We'll also be discussing the parts of FHO that are ending, including access bonus and outside use negation, as well as comprehensive care capitation payment. Let's kick things off with the newly introduced hourly time-based payments. So, how do the time-based payments work? These payments are received through codes that are billed at $80 per hour, broken into 15-minute increments, with a maximum of 14 hours per day. This approach is designed to support longer patient visits and part-time physician work, while also recognizing the wide range of responsibilities that extend beyond direct patient care. Hourly payments can be billed under three distinct categories. Direct services. This refers to time spent with patients directly. This will also include bedside teaching and providing concurrent patient care, including phone consultations. Phone consultations will be billed at 100% of the hourly rate if the physician is present in their clinic and 85% if they are not. Indirect services. These are activities such as charting, reviewing labs, billing, and other tasks directly related to a patient, but the patient is not present. Clinical administration. This is work that includes roster management, chronic disease oversight, and other clinical leadership tasks. A few important points to keep in mind about this new implementation. Hours billed are based on total daily hours, not the time spent per patient. Billing is also capped at 240 hours per month, which equates to a 4-week block. Nurse practitioners and physician assistants are not billable under the hourly rate. For instance, if a nurse practitioner sees patients independently, that time cannot be billed, though consultative discussions or administrative reviews may qualify. Home visits and palliative care are still under review for inclusion, while hospital work has been excluded. Although administrative time is billable, there are safeguards to prevent excessive billings here. Indirect care and clinical administration can't exceed 25% of the total hours billed. Clinical administration can be up to 5% of the sum of direct care hours and indirect care hours. In short, the hourly payment model is a significant step towards acknowledging the full scope of physician work, offering greater flexibility while ensuring fairness and sustainability. The FHO Plus model includes not only hourly based payments, but also significant increases to existing patient attachment bonus codes and new bonus codes for patient attachment. Established physicians will receive between $100 and $180 per new rostered patient, depending on the rural index for Ontario score and the patient age. While new graduates will receive between $150 and $270 per new rostered patient based off those criteria. The incentive is designed to ensure that patients have access to care and are not just added to rosters without being seen. Implementation details for the new codes are currently being developed and have not yet been released, but you will still need to bill the Q200, the rostering code, for rostering of a new patient until further notice from the ministry and the OMA. As for new patient attachment codes, a new fee, Q054, is being introduced for mothers and newborn patients, paid at $350 for physicians enrolling both an unattached mother and newborn within 2 weeks of giving birth, or an unattached mother after 30 weeks of pregnancy. A new code for multiple births, Q055, will also be introduced. The Q055 code applies when there are multiple births, such as twins, and a physician rosters the newborns within 2 weeks of delivery. This fee is $150 per newborn and is billed alongside the Q054, Mother Newborn New Patient Code that we just introduced. The HCC Healthcare Connect Upgrade Q056 code is also a new addition and is used when a doctor initially thinks a patient is not complex or vulnerable, but their clinical judgment considers the patient to be complex or vulnerable. In this case, the doctor can bill using the HCC Q056 code. As for existing patient attachment codes, the Q053, which some of you might be familiar with, is the Healthcare Connect complex fee, and this will increase from $350 to $500. This code applies to primary care services for patients identified as complex and vulnerable who have been referred through the Healthcare Connect or HCC program. Here are some takeaways from the patient attachment bonus as well as codes. These fees are applicable to newly enrolled patients in the FHO group and may only be billed once by the same FHO group enrolling the same patient. These codes are eligible for all PEM groups. The patient attachment bonus can only be billed for a newly enrolled patient at the time of the first billable service. The first billable service does not include services provided outside of the usual family medicine clinical practice setting prior to enrollment. If the group chooses to de-enroll a new patient within 12 months of formal enrollment, the fee paid to the group will be recovered by the ministry. The patient attachment bonus cannot be billed in addition to the Healthcare Connect payment, mother newborn new patient fee, and multiple newborn fee. Ensuring your patient roster is accurate and up to date becomes even more critical under the FHO Plus model. Our team can help you verify all eligible patients are properly attached to your practice, identify and resolve roster discrepancies, maximize patient attachment bonuses, and streamline the rostering process for new patients. Now, let's get into what is being enhanced in the FHO Plus model. In-basket codes constitute a large part of FHO physician billing, which is why they are very important for both compensation and patient care. Shadow billing, also known as the percentage received for in-basket services for rostered patients, will increase from 19.4% to 30%. This increase applies to all in-basket services, included in-basket special visit premiums. This increase represents a significant boost in revenue for physicians and reflects the work and effort required to deliver routine services to patients on a daily basis. It's also worth noting that the fee-for-service hard cap will continue to be measured on a group level rather than each individual physician. Our team can ensure that your group stays on track and keeps your group below that threshold. Continuing on the topic of billing, select office procedures will also see an increase in their fee value up to 50%. The list of procedures included in this increase is quite vast and extensive and includes services commonly performed in your clinics. Some examples that we'd like to give of common procedures that you will see included in the increase to 50% are the G365 cervical screening specimen collection or pap smear, the G378 IUD insertion, all immunizations from G841 through to G848, and Z prefix in-office skin biopsies like the Z101, Z116, Z117, and many more. You can find the full list of procedures included in this increase on the OMA website, or feel free to reach out to us and we'd be happy to provide it. A major part of being an FO is agreeing to take on after-hour shift, which include weekday evenings from Monday to Thursday, as well as some weekend shifts. While working after hours benefits both you and your patients, it is acknowledged that physicians are not adequately compensated for this time. With the FO Plus model, you can now expect the Q012 after-hour premium billed for rostered patients seen after hours to increase from 30% to 50% of all eligible services billed after hours. This is a major win for physicians as this increase is headed in the right direction of fair physician compensation. The after-hour premium code, Q012, is often one of the most overlooked billing opportunities for physicians. Our advanced billing services ensure you never miss the Q012 on your claims. Another significant improvement in the FO Plus model is the current in-basket hospital services will now be treated as out-of-basket services. This means they'll be paid at the full fee-for-service rate, ensuring you receive appropriate compensation for hospital-based care. For a long time, patients who were seen at a hospital contributed to a physician's outside use and fee-for-service hard cap. This will no longer be the case. You will not have to worry about the outside use accumulation caused by inpatient services provided by another GP, as well as its effect on the physician's hard cap who is providing the service. To encourage physicians to take on leadership roles within FO groups, A new enhanced group management leadership payment, or GMLP, of up to $100,000 annually will be introduced. This is 4 times the current rate of $25,000 per group. The enhanced GMLP will be provided in return for the group lead or leads, providing leadership to ensure faux contract compliance generally, including appropriate after-hour availability and care specifically. So if you're taking on leadership roles within your group, this will be especially valuable and meaningful to your current role. As a note, groups will not automatically receive 4 times the GML payment. The ministry is working on requirements to achieve this higher pay value, and we will make sure we keep our groups up to date. The current GMLP of up to a maximum of $25,000 will continue to be maintained. The FHO Plus model is now making it even easier to establish and maintain FHO groups. The original rules for establishing a FHO group required that when all physicians cannot be in the same location, there must be at least 3 physicians in each location. Now, if all physicians in a group cannot be in the same location, there should be at least 2 physicians in each location, 1 less physician required than before. This change was primarily in response to physicians in Northern Ontario, where there is limited opportunity for close collaboration, but they had a need to work in a group. These are the additional rules about co-location that you should also know about. In areas where the RIO score is 0, close proximity is defined as the foe's locations being within a 5-kilometer radius of one another. In areas with an RIO score of 1 to 5, close proximity is defined as being within a 10-kilometer radius. In areas with an RIO score of greater than 5, close proximity is defined as being within 30-kilometer radius. Where physicians fall outside of these proximity parameters, applications from groups will be considered on a case-by-case basis. For clarity, these guidelines do not apply to existing FHOs that are adding physicians to their existing group locations. We do a significant amount of work in creating and maintaining FHO groups in Ontario. As this is an incredible, lengthy, and tedious process, we consider ourselves highly skilled in the area, ensuring that physicians who want to transition into the FHO model can do so without concerns. Let's conclude by discussing what will not be transferred from the FHO to the FHO Plus model. Starting next year, negation will be removed and the access bonus will be eliminated, with revenue being offset by the hourly, time-based payments. Since this was a significant source of stress for physicians, as outside use is patient-driven and often outside of the physician's control, we're glad to see its removal, which will, in turn, reduce your stress. It is important to note that although negation is being removed, it doesn't necessarily mean that outside use won't matter. More recently, the OMA announced that there will be an alternative financial consequence for FHO physicians who fail to meet a continuity of care threshold, which we will review in further slides. So I'm sure a lot of people are wondering, what is the continuity of care threshold? The arbitration decision states that continuity of care includes in-basket services you provide to your own roster patients, in addition to in-basket services provided by other doctors in your FHO group, locums registered with your group, and any designated GP-focused practice physicians, and even family doctors working in hospitals or emergency departments. Those are all considered continuity of care. The threshold has been set at 75% and is calculated by dividing all those in-basket factors that we just mentioned by all in-basket services provided by any family practice specialty physician. It should also be noticed Noted that unlike the case of negation, where there was a financial consequence of a dollar for dollar deduction, this will not be the case with the faux plus model. Instead, if a physician's continuity metric falls below 75%, a 15% reduction to the capitation rate will be applied quarterly. The good news is that the reductions will not be applied right away. Affected physicians will receive a notice that their continuity of care has fallen below 75% in any given quarter. They'll also have a fair chance to make improvements in the following quarter before any financial penalty is applied. And finally, the other part of the faux model that is ending is the comprehensive care capitation payment. As we discussed earlier, capitation consists of two parts: the base rate payment, which accounts for about 80% of the capitation payment, and the comprehensive care capitation payment, which accounts for about 20% of the capitation payment. That 20% is now being redirected into hourly payments and other fee increases, which we had previously mentioned. A question we're frequently asked is, how much will I be making in the new Faux Plus model in comparison to what I make now? And it's a really important question. The overall increase in income is said to be around an average of 18% more than what you're currently making in the faux model. So, given these rough numbers, if you're a physician who has a current roster of about 1,300 patients, works roughly 45 weeks per year, works around, 25, 30 clinical hours per week, and has a current income breakdown similar to the one shown on screen here, then your yearly total income would go from about $335,000 to around $395,000. As you can see, this would be the yearly revenue increase of on average 18% in the faux model. Of course, these numbers are really a rough estimate and are provided for illustrative purposes only to give you an idea of what you can probably expect. The OMA has created a virtual calculator available on their website that allows you to input these same factors based on your most current RA and provides a rough estimate. We'd be happy to walk you through putting these numbers in and making sure you have an approximate estimate of what your income may be in the Faux Plus model. With all of these new changes being put forth, the Doctor Care team is here to support you in preparing for the implementation of the Faux Plus model. Ensuring your patient roster is accurate and up to date becomes even more critical under the Faux Plus model, where Doctor Care can help you verify all eligible patients are properly attached to your practice, identify and resolve roster discrepancies, maximize patient attachment bonuses, and streamline the rostering process for new patients. The new hourly payment structure requires careful documentation and tracking. Our team can implement systems to track time accurately, ensure you're capturing all eligible administrative and indirect service times, optimize your billing to maximize the 14-hour daily limit, and provide clear documentation for audit purposes. If you're forming a new FHO or adding physicians to an existing group, Doctor Care can assist with navigating the updated FHO agreement requirements, understanding the co-location rules and RIO score implications, managing the governance agreements, and ensuring compliance with the new FHO Plus requirements. We really do have deep expertise in FHO creation and management. We formed over 58 FHOs in the last few years, added over 200 doctors to these FHOs, and we're currently managing over 100 FHOs in Ontario. As we said before, approximately 25% of all FHOs in Ontario. And lastly, our billing experts can help you ensure you're maximizing all available revenue streams under the FHO Plus model. This includes ensuring capture of billings at higher in-basket rates, optimizing after-hour premium billings, maximizing out-of-basket billings, such as diabetic, and ensuring billing errors are corrected and resubmitted for payment. As we come to the end of the presentation, let's go through some key takeaways for you today. First, the FOPUS model will provide physicians with a fairer compensation structure by addressing long-standing gaps through multiple enhancements, seeing an overall average income increase of about 18% compared to the original FO model. Moreover, physicians will see broader recognition of their work, with new hourly payments acknowledging the full spectrum of direct and indirect patient care activities, as well as new bonuses that encourage appropriate rostering and regular patient care. Lastly, the administrative burden associated with access bonus negation will be reduced, removing a significant source of stress and complexity from your day-to-day practice. All of these new changes are set to be implemented on April 1st of next year, 2026. And as the final details roll out, we will continue to update you. Ontario's FO Plus model will reshape how family physicians are compensated, impacting clinic workflows, revenue streams, and patient care delivery. As a special offer for those who joined us today, you can book a complimentary FO Plus income analysis with our team to help you see how the new FO Plus model can impact your practice and answer any questions you may have. Our team of billing experts understands the complexities of physician billing and practice management, and we're prepared to support you through the transition to FO Plus, ensuring you're positioned to take full advantage of these positive changes. To book your analysis, you can fill out the form on the link, which we just shared in the chat section of this webinar. Or you can reach out to us at info@doctorcare.ca to schedule the meeting. Thank you everyone so much. We're going to take a few Q&A questions, 4 or 5. As we mentioned before, if we don't get to your Q&A question, we will make sure to respond to it after the webinar. So don't worry about it. One of our team members will be sure to follow up. First question being passed along, when will the FO Plus model officially take effect and will there be a transition period? So the current model will take effect on April 1st, 2026. Physicians will automatically move from the FO model to the FO Plus model, and you won't need to reapply for that FO Plus model. There may be a short transition period as new billing codes and processes are rolled out, but it should come into effect as of April 1st. For existing patients already rostered, do I still qualify for the new bonuses? So unfortunately, no. The rostering incentive will be paid out for unattached patients only. So if you already have a roster of 1,000, unfortunately, you can't bill the rostering codes for all of those patients. But for any new patient you roster to your FO Plus, you will be able to bill those incentive codes. I have a question around the Q012 after-hour billing. If the 50% premium applies to all services, including procedures. So the Ministry of Health has a clear list of codes that the Q012 applies to. It's in the schedule of benefits, and that the 50% premium only applies to that list of codes. It's in the schedule. If you want to see a list, we'd be happy to share it out. And that list looks like it's staying consistent from the FO to the FO Plus model. A question coming through, how does the removal of the comprehensive care capitation payment affect me? So a reminder, the comprehensive care capitation, that's the part of your capitation, that's about 20%, right? The 80% is the base rate payment. So the 20% that was tied to that comprehensive care capitation that's being removed is really being redistributed into new income streams, mainly the hourly payments, higher shadow billing, and enhanced procedure fees. So what we're expecting to see is really a net increase in revenue from this redistribution rather than a decrease of that 20%. A question around outside use still being tracked, even with the access bonus going away. So yes, groups will still be expected to capture, we spoke about that continuity of care threshold, so still the 75% continuity of care threshold. So this is an average spread amongst the groups, and it's still the same metric that the ministry uses today. So the ministry is actually tracking continuity of care today. We just saw a stat come out, or we just read a stat that in 2024, of the approximately 600 FHOs in Ontario, only 75 or so were flagged as not meeting that metric, the 75% continuity of care threshold metric. So that really means that the vast majority of physicians doing the regular practice won't be affected by this continuity of care, but it will be important to continue to track that and make sure that patients are coming to see you rather than going to walk-in clinics. And just one last question here. Like I said before, I can see there's a bunch of questions coming through, so we'll make sure to follow up after the webinar to respond to the rest of them. But the questions coming in on the continuity of care, can doctor care help with this? As we help with access bonus right now, and we definitely can. We're putting some guides together on effective strategies to help you maintain the continuity of care for your patients, right? So through tailored communications, tools to monitor patient engagement, and then we're definitely going to update our practice care reporting to make sure that we're tracking patients who are going to outside clinics so that you'll have the knowledge there and you can be able to decide how you want to handle that. So like I said, we've got a bunch of questions. We won't be able to get to all of them right now, but we will follow up for sure. So I just want to thank everyone so much for joining us today. On behalf of Doctor Care, we appreciate your participation and we hope you found this information informative and valuable. If you have any questions or feedback, please feel free to contact us. As you can see, our contacts on the screen, info@drcare.ca. And really just wishing everyone a wonderful day and thank you very much.